Good afternoon, everyone. I warmly welcome you all to today's insightful webinar organized by OPTOBHARAT. Myself, Sadaf Khan, and I'll be your moderator for today's session. On behalf of OPTOBHARAT, I sincerely thank each one of you for taking your time to join us. Your presence reflects your commitment in advancing knowledge in the field of optometry. OPTOBHARAT is dedicated to build the future of optometry together by connecting students, professionals, and experts through education, innovation, and collaboration. Today's topic is excellently innovative and thought provoking. From visual acuity, so today's topic is extremely relevant and thought provoking. From visual acuity to visual performance, expanding the scope of optometric care. This session will help us move beyond traditional vision testing and understand how we can truly enhance patient outcome in normal clinical practice. It's my privilege to introduce our esteemed speaker, Mr. Nikit Kundra, Director, Eye Luminous Speciality Eye Care Clinic, B.Optom, M.Optom. He brings valuable clinic expertise and real world insight that will definitely enrich and understand today's. So, we are truly honored to have you with us. Before we begin, a few quick guidelines. Please keep your microphone muted during the session. You may drop your question in the chat box. We will have a Q&A session at the end. Please stay till the end to receive your e-certificate. Now, without further delay, I would like to invite Mr. Nikit Kundra to take over the session. Sir, the stage is yours.
Thank you for that kind introduction. I'm truly grateful to have here. So, let me just share my screen. So, good morning, everyone. So, uh, let's just begin. Uh, one second. So, when we think about vision, the first thing that comes to our mind is visual acuity, that is 6 by 6, 6 by 9, or 6 by 12. But patients with perfect normal visual acuity still complain of headache, difficulty in reading, poor concentration, and visual fatigue. So the question is, are we evaluating the true vision or just measuring the clarity? So let me just start with a simple question that if a patient has 6 by 6 vision, is their visual system is normal? In clinical practice, we often see that patient complain करते हैं कि like I can see clearly but can't concentrate. Words move while reading. Headache हो रहा है screen use करने के बाद and it takes me 3 to 4 seconds to shift focus from near to distance or distance to near. And lines got skipped while reading. So are we measuring the visual system clearly or not, or just we measuring the clarity? So, because the traditional optometric evaluation focuses on visual acuity and refraction, acuity, refraction, and ocular health, and the missing component that most of the optometrists miss is binocular vision, oculomotor control, and visual processing. Because 20 by 20 vision measures clarity, not performance, and also the studies suggesting that 20 to 30% of school-going children have binocular vision or visual efficiency problem despite having normal visual acuity. So these patients often pass routine eye examination but still struggle to see. So the question is that what are we missing? So this brings to our concept of visual performance. Visual performance is not just about seeing clear. It's about how efficiently both eyes are working together. One second. So this is an integration of eye alignment, eye movement, and focusing, along with brain processing. And there are different components of visual performance that includes बाइनोकुलर विजन, दैट हाउ बोथ आईज आर वर्किंग टुगेदर, कि हमारी जो दोनों आईज है वो कितना एफिशिएंटली साथ में काम कर पा रही हैं. और अकोमोडेशन सिस्टम मींस दैट व्हाट आर द एबिलिटी ऑफ आवर आईज, के जो हमारी आईज का लेंस है एंड उसके जो एक्स्ट्राओकुलर मसल्स है वो कितना अच्छा साथ में काम कर पा रहे हैं टू फोकस. oculomotor skills, that how efficiently our both eyes are moving together. एंड द विजुअल परसेप्शन, दैट जो हमें दिख रहा है वो ब्रेन उसको कितना अच्छे से उसे रिसीव कर पा रहा है. एंड द विजुअल मोटर इंटीग्रेशन मींस कि जो विजुअल कंपोनेंट्स हमारे ब्रेन को रिसीव हो रहे हैं वो बॉडी को उसका किस तरीके से रिस्पॉन्स दे रहे हैं. So all these are the components of visual performance, and any problem that occurs in this visual performance can lead to overall can affect overall performance of an individual. So let's just begin with explaining a single one. First one is binocular vision. Binocular vision means how both eyes are working together. So binocular vision is a combination of simultaneous perception, which means how our both eyes are collaborating with each other and coordinating with each other to see clearly. And the other, which brings to the next concept of fusion, when the image received from the one eye and the other eye, how the image got fused. And the third part that can lead to stereopsis. Stereopsis means the 3D vision. 3D means if you want to see your 3D vision, just close your one eye and have a walk. You can see what is the effect of your 3D vision that you have in your daily life. And clinical relevance to this binocular vision, and any problem in this binocular vision can lead to academic difficulty, poor attention, and asthenopic symptoms like eye strain, headache, and other asthenopic symptoms as well. And the second system is accommodation and version system. In this detailed evaluation, we just don't measure the clarity, we measure accuracy, flexibility, and sustainability. And any dysfunction in this accommodation and the version system can lead to blur at near, visual fatigue, and avoidance of reading, and difficulty to fixate and focus. And the other part is oculomotor function. Oculomotor function means the ability of our eyes to read and track something, which includes saccades. Saccades mean how our eyes are moving from one point to the other point. Like when we are reading, we are moving our eyes from one point to the other point. Then how efficiently we are able to do this? Pursuit means smooth eye movement. That is means when we are reading something, how efficiently we are going to track that thing. And the third part is fixation. Fixation means the attention, that how attentively we can use our eye movements and read something. And any dysfunction occurring in this oculomotor function can lead to skipping of lines, and finger pointing. Patient often come to the clinic and say, "Okay, I I can see near things like this. I have to always point finger on the object," and slow reading speed. Because and this brings to a concept of perform. Sorry, visual perception, because our eye sees and brain understands. As you can see in this image, this image is stable and not moving, but our brain is perceiving that the image is moving because of the repeated color patterns and the same design of the image. If you focus on the center, this is a very clear example that our eye see, brain understand, because when you focus on the center, you see the sides of this image is moving, because our brain is appearing, the image appearing to our brain is showing that the image is moving. And the visual perception consists of visual discrimination, visual memory, visual figure ground perception, visual spatial relation, visual closure, visual sequential memory, and visual form consistency. So this alone is a very big topic that we can discuss maybe in some time in future. And all these are and any dysfunction occurring in these seven components can lead to learning disabilities. And the when the pay and 30 to 40% of the children usually have learning. Nowadays there is a big gap that occurs in the practice, that that the patient nowadays are treated as a refractive cases, but they're actually suffering from functional vision issues. And when the children are having such functional vision issues, they are labeled as lazy by their parents or teachers, that these children is lazy, but actually they have learning disabilities, or maybe they have a poor attention span that can lead to their visual problems, but they can see 6 by 6 or clearly. So we have to move from beyond 6 by 6. So let's just understand this better with the case example. So this case came to our clinic 2 months ago, and he's a 10-year-old child having a complaint of poor reading and headache. His visual acuity and best corrected visual acuity is 6 by 6. The near point of convergence, that are ability of our eyes to converge at the nearest point, is 12 centimeter, and his PFV values and the converging abilities is 10, 12, and 8. That is very reduced. His vergence facility, that is our ability of our eyes to converge and diverge efficiently, is low. And you can see in this eye tracker report that his horizontal gaze and vertical gaze movement have a lot of spike, which means he is not able to move his eyes in smoothly or firmly. And his gaze heat map also shows that his eyes are not stable. So and the diagnosis for this patient is convergence insufficiency and poor saccades. So what could be done in this such kind of patients? So vision therapy, the game changer. So what is vision therapy? Vision therapy is a neuroplasticity based training that helps to improve eye coordination and brain processing. In this, we just don't prescribe lenses, we train the entire visual system. And you can see now what just 2 months of vision therapy and what are the results for that. You can see a stable gaze, and what was the previous report, you can see, and you can clearly see the difference now. A stable gaze, and the heat map also shows that the gaze is very much stable, and his eyes are moving as per him, not because he is not able to controlling his eyes before. And in this, the outcomes were NPC got improved to 5 centimeter, PFV values goes to 20, 25, and 20, reading got improved, and symptoms got resolved. So vision therapy also have a different type of modules, which includes binocular integration, version system, anticipation, accommodation, oculomotor control, and visual perception, that how our brain processing, and near and distance dropsy. So binocular integration means how we have to train the patient to use his both eyes together. And with the help of version system means the how the a patient can converge or diverge easily. We have to improve that system. And in cases like amblyopia, we have to work on anticipation, accommodation, and oculomotor control is all and the working on upon oculomotor control helps a lot of patient. And then the last part is visual perception, and the entire thing can lead to improve the near and distance dropsies, because our goal is not to improve visual acuity, our goal is to improve stereo acuity. Stereo acuity means stereopsis. So conditions that can be managed easily with vision therapy includes vergence or accommodative dysfunction, amblyopia, strabismus associated with phoria, and learning-related visual problems, with also digital eye strain. Now you can see this patient that came to my clinic around 3 to 4 months ago. He came, and someone has diagnosed him esotropia. And upon doing a detailed evaluation, and when I heard his symptoms, I the diagnosis I made that is esophoria associated with accommodative esophoria. Then after 3 weeks of vision therapy, you can see the difference clearly. So now, what should be your clinical approach while assessing the patients? Detailed. Firstly, you should do a small battery of rest while doing general refraction, and which includes NPC or NPA. Like you can show a simple pen target to the patient after doing refraction and ask him to focus clearly and see that at what is the nearest point he says that now I am seeing double. You can do NPA, that by covering one eye you ask him to focus an object and ask where the object is getting blurred. And if the patient if the patient during refraction says that the now I'm getting blur here only, not under the normal parameters, then you should go for a detailed binocular vision assessment. Then after doing binocular vision assessment, you should do the functional diagnosis, and depending upon that, you should customize a waiting plan and continuous monitoring for the patient. So what difference it will create if you do such things? Then what difference it will create in your clinical practice? This can lead to high level patient satisfaction. The level of the patient satisfaction after vision therapy is ultimate. This provides full visual efficiency to the patient. And the patient almost also sees that, okay, I can see this much clear. I don't know. And better patient outcomes as well. And this will also create a professional differentiation from general clinical evaluation to an advanced optometric clinical evaluation and treatment. So don't just help the patient to see clearly, help them see efficiently. This quote that we follow always, that just our target is not 6 by 6. So thank you. Now I'll happy to take any questions now.
Okay, I want to ask, hello.
Hello.
Okay, so how is vision therapy permanent? Let's say one go through vision therapy, from example the case, and then we can see NPC is now improved. Are there any chances of NPC to be receded after stopping the vision therapy?
Your voice was breaking. Can you repeat your question again?
Okay, I am saying how long does it take? Okay, is vision therapy solution permanent? Let's say for the case number one, NPC was now corrected to 5 centimeters. So after vision therapy, is that NPC not going to be reduced?
Mm-hmm. Okay, you can see. See, in
Mm,
this, the NPC is 12 centimeter. That is
yes.
receded. Okay,
Mhm.
receded means the NPC is fluctuating. Sometimes they are saying at 14 centimeter, sometimes they are saying 12 centimeter. The
Yes.
object is getting double. Okay, and after the vision therapy, it comes to 5 centimeter. That means
Yes.
that is the normal range. And
Mhm.
by you are asking me that how this came.
Is this going to be permanent after they
Yes,
stop?
yes. This is going to be permanent.
Okay,
It
okay.
is going to be permanent because in this we train the neuroplasticity of the brain to
All
focus
right.
and improve. But if the patient, we have to always counsel the patient that you should know, you should always maintain this to make it stable.
Okay, okay, sure.
Yes.
Thank you.
So there are a few more questions in the chat box. I will read it out. So the first question is by Junaid. The question is, what are the different type of vision therapy method that can give in limited resource?
So different type of vision therapy method that we can use is for convergence insufficiency. You can have some basic instruments like you can have a Brock string or you can made it as well by your own creativity. You can make a Brock string, and with this you can improve the converging ability. And for the accommodation, if you have a trial set, you can do the accommodative therapies brilliantly. If you have just a trial set with just a help of a trial set, and another part is for the anticipation. In this trial set only, we just need a trial set only to give a good vision therapy, and you have to use this trial set. After doing refraction, you can add red green glasses, and after adding red green glasses, just have some basic bar reader or GTVT card that can improve the anticipation part. And for the when all these parts are improved, you can have some online softwares to improve the stereo acuity as well. And but if you do these therapies clinically good, the stropsis will be also good clinically without any online softwares or VT.
Okay, so next question is by Kanchan. Can vision therapy improve one eye amblyopic patient?
Yes, vision therapy will the amblyopia therapy can help the one eye amblyopic patient. Firstly, we have to diagnose that what type of amblyopia is it. Is it strabismic amblyopia? Is it refractive amblyopia or any other amblyopia? What kind of amblyopia is this? Firstly, we have and what is the age of the patient and what are the symptoms of the patient and what are the signs that we can see. And firstly we have to evaluate the retina as well, that is the retina is normal, is any ocular structure having any kind of problem, and if everything is good, we have a green signal to do the amblyopia therapy, and that will definitely improve.
There is one more question, sir. This question is by Khushi. How do you differentiate between a case that needs vision therapy versus only refractive correction?
If a After doing refraction, if a patient having 6 by 6 vision, we just give them the glasses, and after 4 days 5 days patient again came to the clinic and say, with the glasses I'm oftenly having headache, and before doing refraction he was also doing this same. So when the then we have to evaluate another parts, which include the NPC or NPA evaluation. You can do just generally just by having a pen. Just have a pen, like just you have a pen and ask the patient, I'm moving this pen near to you, and once it become double, just let me know. Then bring this pen near to his nose, and the point he says it is double and not able to make it single, note that reading, and then move it back, and then again note the reading. You have an NPC value with you. For the NPA, just you have a near vision book in your trial set, and may close one eye and ask him. I ask the patient that I'm moving this close to you. You have to just read, and once it becomes a little blur, just let me know. Then you have your NPA values, and if the those NPC and NPA values will tell a lot of things. And if any problem occurs in this, you can refer the patient to full binocular vision assessment, and you can now see in detail that what binocular vision patient having, and depending upon that you can plan a vision therapy plan for this.
So there is one more question by Junad. Up to how many ages we can prescribe vision therapy for amblyopic patient?
See, the for the amblyopic patient, I generally say that, but in my clinic I have done with my own hands of a patient having 35-year-old. I have made her 6 by 36 to 6 by 6. Yes, in the adult age the time of the therapy got increases, but it improves because it just depend upon the neuroplasticity. Once the neuroplasticity of the brain got improved, the condition can be treated.
Yes, thank you so much, sir, for the wonderful and informative session. On behalf of OPTOBHARAT, I would like to express our heartfelt gratitude to
Thank you.
Mr. Nikit Kundra for sharing such valuable knowledge with us. Also, thank to all the participants for your active participation. We hope this session had added value to your journey today. Please don't forget to fill out the feedback form and stay connected with OptoBharat for more such educational event. Have a great day ahead. Thank you. Goodbye.
Thank you.
Thank you.